So with that, I want to welcome everyone to the 11th Annual Montana Healthcare Forum Conference, and I am Jean Branscombe, and I'm going to serve as your host for today. My regular day job is actually working at the Montana Medical Association as the CEO. On behalf of the healthcare and business communities, we want to extend our appreciation for your attendance today. We have rolled in extra coffee. It's been a long week, and many of us were up till the wee hours of the morning with the special session, and so please feel free to get up when you need that extra shot of coffee and continue to join us after that point. Today you're going to find that we have dynamic speakers and panels on the agenda who are sure to spark your interest, and we encourage you to be curious, ask questions, and share your thoughts throughout the day. You know, this annual forum started during the Martz O's administration. That was a concept born 15 years ago, building bridges of understanding and creating a home for new ideas. Put in place by a compassionate governor who also understood the business realities and the cost of health care associated with that. We lost Governor Martz recently, and may her and her Lieutenant Governor call her O's rest in peace. Having worked on that first forum as part of that administration, I am proud to stand here today as much work has been done through partnerships. In fact, the first forum generated a proposal for a hospital bed fee, a fee that remains in place today to leverage federal matching monies to pay hospitals to offset their costs for treating our Medicaid patients. And I am proud to stand here today as our businesses in this state have leaned forward to be part of the conversation on healthcare to provide their perspective, and the healthcare community who's listened and have shared the challenges they face as well. Many of you have been supporters from the very get-go, and I want to thank you, and I also want to thank our sponsors today. So if you're here from one of these organizations, if you wouldn't mind standing so we could give you our appreciation for your sponsorship. That includes Pacific Source Health Plans. I think we had Todd here earlier. Thanks. Yep, we got a crowd back there. Thank you. Blue Cross Blue Shield of Montana. The Montana Healthcare Foundation. Aaron. We have EBMS, Montana Medical Association, and the Mountain Pacific Quality Health. We've got through here. The Montana Hospital Association, Delta Dental Insurance, and Midland Claims. You know, and I also want to shout out to Governor Bullock and Director Hogan and Jess Rhodes, who aren't in the room at the particular moment, but they've really supported conversations in their office and have paid attention to healthcare over the years that they've held that office. And part of that has been to initiate an advisory group to transform the healthcare delivery system. Many of you serve on that healthcare delivery system, have put a lot of time into that as well, and just want to give you, again, an expression of thanks for the time and efforts you're putting to really look for solutions that work for the state of Montana. Because it's really no easy task to transform a delivery system that's been in place for years and is very complicated. There are very many moving pieces, and frankly, we're taking care of humans, and they're just not widgets. They each have their own unique needs. You know, I grew up on a family farm, and we were a 4-H family. And you might think of 4-H and the showing of animals, sheep, cattle at the county fair, baked goods. But you know, 4-H isn't just cows and cookies. It offers many more things, hundreds of programs. It develops leadership. And healthcare is the same. It's just not about cuts and bruises or surgery and stitches. It's about economic growth, good paying jobs in Montana, and thriving communities that offer a place to work, to learn, and to get and stay well. It's about having a healthy workforce and knowing that comes at a cost, a growing cost to our businesses and to each one of us. We need to work together to keep people well and to keep these costs down. And the timing could not have been better. Talking about cuts and bruises, our legislators have been in town with their sleeves rolled up to manage a revenue shortfall. Our governor called for a special session recognizing more that cuts in services could not resolve this problem. It would hurt our vulnerable populations far too great. And our state legislators stepped forward to consider ideas, and they expanded the call to include some ideas of their own. And I'd like to recognize any state legislators. I know you left probably at 1 in the morning, but if anyone made it yet today, I know we have some joining us. Could you please stand? I haven't seen anyone, but I do know that they had a very late evening last night. If you see your local legislator, or if you have the chance, please reach out and give them a shout of thanks. You know, for them to leave their family and their businesses to come to town and deal with a budget issue, to really understand the implications to our vulnerable populations, to providing health care services, and the impact to access to medical care. Just give them a shout, give them a thanks, and thank them for the service they do for Montana. And we know that health care is a national issue. Unfortunately, we have a congressional delegation that's out there speaking on behalf of our needs and the particular needs of a rural state, actually a frontier state. And I want to recognize the staff that are here representing our congressional delegation. So we have Deborah Franson from Senator Tester's office. And I think Robin Madison may join us later. Gilda Clancy from Senator Daines' office. And Brett Simons from Congressman Gianforte's office. We appreciate all the work that you do as staff, and again would invite you as attendees to grab these folks over coffee or break or over their lunch and visit with them about the healthcare issues and what's on your mind as businesses in regards to that as they tackle big issues at the national level. And last, I want to thank the Planning Committee, what included Coco Ballou, Richard Miltenberger, Bridger Malum, and then our lead coordinator who's out front, Stacy Dorrington, and our ever-gracious leader, Webb Brown. So if you want to stand, if you're here, I think Richard's in the room anyway. Thank you, Richard. You know, this planning group actually represents a larger group who has dug in and planned this agenda for many years, and we really rely on the feedback from the year before's agenda, putting forward an agenda for you to hopefully find thought-provoking, a little controversial at times, but also just well-balanced. And so feedback does assist us in the direction of what will happen next year. So on the tables, you're going to find some evaluation forms throughout the day. So please be sure to complete your evaluation form and let us know your thoughts and your ideas for next year. As a bonus, for those that complete that form, you're going to be put in a drawing for a $50 gift card. So be sure and put your name to that as well. So this year's theme of this particular session talks about us working together and how important that is. Collaboration among healthcare providers and systems is key for us moving forward, and collaborating with our business partners and our payers are extremely important as well. It's been a long 3 days, and we actually had looked forward to hearing about the special session from Governor Bullock, but we learned late last evening that he would not be available to join us this morning. That will keep us on schedule, but we do know that he has got some bills that are landing on his desk and some decisions for himself to make as the day grows on. I do want to shout out, though, again, to talk about the efforts of Governor Bullock to really lower healthcare costs and invest in Montana's healthcare system. During his time in office, Governor Bullock has worked on the bipartisan initiatives such as the HELP Act, through which over 80,000 low-income working Montanans have found healthcare coverage. That kind of mechanism has also helped with the cost shift that has led to increases in healthcare costs for those who pay insurance in other vehicles. Additionally, the Governor's Council on Healthcare Innovation continues to meet and consider innovative multiplayer delivery and payment transformation models that aim to improve healthcare quality, lower cost, and get better patient outcomes. This includes exploring opportunities to collaborate with the private sector to establish a needed data infrastructure that would allow for the exchange of healthcare information. The Montana Medical Association is proud to lead that effort, and many of you are our stakeholders and partners in that effort. We look forward to seeing that advance in early 2018. We also appreciate the work of our congressional delegation again, who are doing their jobs in Washington to make sure that our interests are well protected and to speak about the unique healthcare challenges our state faces. And while they're not able to join us today, we do have video recordings.
Greetings from the U.S. Senate. I want to thank Webb Brown and Greg Thayer for once again hosting this important forum. Over the past 8 months, I've held nearly 24 in-person healthcare town hall meetings, listening sessions, to hear directly from medical professionals, employers, and families about our healthcare system. Regardless if folks were from a Class C town or a AA city, they shared the same concern: healthcare costs are too high. They told me that folks in Congress were putting more uncertainty on their businesses, and they were frustrated because there were no committee hearings, no buy-in from key stakeholders, and no attempt at bipartisanship. Washington, D.C. failed to do its job strictly because of politics, and as a result, our businesses are loaded with uncertainty. Despite the partisanship, Lamar Alexander, a Republican, and Patty Murray, a Democrat, worked together on a bipartisan healthcare solution. Unfortunately, the majority leader pulled the rug out from underneath these negotiations, and he did it to write a healthcare bill that was written in secret in smoke-filled rooms. Rather than work across the aisle to address the rising cost of health care, these one-sided take-it-or-leave-it bills would have kicked millions of folks off their insurance, imposed taxes on seniors, put our rural hospitals and clinics at the risk of closing, and didn't do a thing about the rising costs of health care. These bills would have taken us back to the old health care system, the system where we spent more money for less care. And to make matters worse, last month, the President announced he will withhold critical cost-sharing reduction payments. I appreciate getting a letter from the Montana Chamber of Commerce this summer. You warned of the consequences of getting rid of these payments because it will cause insurance rates to go way up, and you were right. Quite frankly, too many in Washington, D.C. and in Helena are failing to defend Montanans from these harmful out-of-pocket increases. That is unacceptable, and it is time to stop playing politics with health care. That is why I support the bipartisan Murray-Alexander compromise, which restores CSR payments and paves the way for a bipartisan solution to lower health care costs and increase access to care for folks in Montana. It provides certainty and stability to health care. I'm also sponsoring the Individual Health Insurance Marketplace Act to create a permanent reinsurance program to help cover insurance claims by the sickest Americans. The Marketplace Certainty Act to stabilize insurance markets, the Spike Act to increase transparency for prescription drug pricing, the SAME Act to strengthen Montana's Medicaid expansion, the Restoring Rural Residencies Act to bring more docs to rural hospitals, and the Addressing Affordability for More Americans Act to help middle-class Montanans afford quality health insurance. These are the folks without premium assistance. These bills will help create a healthcare system that works for all Montanans, a healthcare system that improves certainty for small businesses and families. Together, we can accomplish this. Your work is critically important. We face major healthcare challenges, and folks are going to have to work together to get solutions across the finish line. Republicans and Democrats are going to have to work together. We must get this right. Our health and our economy are depending on it. By working together, we can increase certainty for local businesses, save Montanans money, and make our state healthier. Please keep up your great work and stay in touch.
Well, welcome to Helena for the annual Montana Healthcare Conference. I've seen your agenda for the day, and it looks like you'll be having some great conversations because healthcare is a challenge, and delivering healthcare in a rural state like Montana is even more challenging. But there are some really innovative solutions emerging to healthcare delivery and communications. In fact, just last month, over 700 Montanans came to the Montana High Tech Job Summit, which I held in Missoula. I co-hosted that with the Montana Chamber Foundation. Every business is becoming high-tech in Montana, including healthcare. We have telehealth, of course, but we're also using technology in how we communicate across networks, how patients engage with providers, and in many cases, it's saving the system money too. We also have a real drug crisis on our hands here in Montana. Meth, opioids, and other drugs and substances are wreaking havoc on our communities. 1/3 of the record 3,400 children in Montana's foster care system are there because of meth use by their parents. I'm working hard from a federal level to address these issues, and I know you're working hard at the state and local level. Please don't hesitate to reach out to me with any ideas or updates at any of my Montana offices or my office in Washington, D.C. Thank you so much, and God bless.
I regret I can't join you today for this important forum, but I appreciate the opportunity to check in with you. First, I'm honored to serve as your lone voice in the U.S. House of Representatives. It's a responsibility I take very seriously. I'm committed to being a strong leader for you in Washington. There's no better way to do that than to meet with Montanans in our communities where we work, live, and raise our families. That's one reason I committed to doing a listening tour of all of our counties. And just 2 months after I was sworn in last June, I had met with Montanans in every one of our 56 counties. I talked with some of you along the way, hospital administrators, local leaders, providers, and educators. The knowledge and expertise you share help me be an effective, strong leader in Washington and here in Montana. What I've heard from you is what I heard from folks all across our state. Our healthcare system is broken. Hardworking Montanans are facing another year of higher insurance costs. On average, Montanans have seen their premiums spike 133% since 2013. And next year, about 30,000 Montanans, a majority of the individual market in our state, could see their premiums rise by over 23%. As if unaffordable premiums aren't enough, Americans' choices are disappearing. Nearly 40% fewer Obamacare insurers plan to offer plans this year than last. More than 80% of Obamacare co-ops have failed, leaving hundreds of thousands of Americans without coverage. The system is collapsing under Obamacare, and hardworking Montanans need access to affordable, high-quality health care. I remain committed to enacting market-based, consumer-centered reforms that do actually lower premiums, preserve rural access, and protect those with pre-existing conditions. I'm in the process of forming a healthcare advisory board of Montanans who will help me identify issues with the current healthcare system and suggest reforms to ensure Montanans have access to high-quality care. I encourage you to bring me your ideas for what's needed in healthcare reform. Please call my office or send me a note to my website at gianforte.house.gov. My door is always open to you. Please don't hesitate to reach out to me or my staff for anything. It's an honor and a privilege to serve you. Thank you, and I hope you enjoy the rest of this critical forum.
Well, again, our thanks to the senators and congressmen and their staff for the work that they do. Now, as we begin our program today, please know that we have set time aside after each presentation for questions from the audience. So please hold your questions until that time, and we'll send someone around with a microphone. So with that, I would welcome our first panel to come forward. So Aaron, Bryce, Brenda, Ben, and Wade. You know, I mentioned the Healthcare Forum started quite a long time ago, and I see many familiar faces around the room, and one thing that I know for sure is that when we go back and we could replay what we talked about 15 years ago, we seem to be talking about the same issues today. And as we hear from our congressmen who are very involved, and if we had state legislators here, they would also indicate their very involvement in really working on these particular issues. And I'm here to say that there are good things happening. Sometimes we get buried down with the rising costs of health care, and we know we're not getting the value that we all want for those dollars. But there are good things happening in our state. There are innovators within our healthcare systems. We have 2 new foundations that are funding very directed funds to helping change the way we deliver health care. And today's forum is about hope. It is about working together with our business partners and healthcare systems across Montana to share with you that good things are happening, folks are working on the issues, and we're looking and we're betting that trend is going to go a different direction, and we'll do that by working together. And with that, I'm just very pleased that we have a panel that's going to give their perspective on what they're seeing as a healthcare snapshot in regards to their travels and their discussions from Montanans across the state. Mr. Wade Johnson is going to be moderating this panel, and he's president and CEO of St. Pete's Hospital here in town. And joining him are Dr. Aaron Wernham with the Montana HealthCare Foundation, Dr. Bryce Ward of the Bureau of Business and Economic Research, Brenda Solozano of Headwaters Health Foundation of Western Montana, and Ben Bledsoe of Consumer Direct. Please note that they've got their biographies in your program, and please join me in welcoming the panelists this morning, and I'll hand that over to Wade.
Thank you. I'm going to scoot over here if you don't mind. Might be easier to stand. So thank you for being here. Excited to be able to share some of the thoughts of our great panelists this morning. And I thought what we would do is we'll kind of work our way through. We have some presentations to share with you, and then we will, I'll moderate a couple of questions for the group and then open it up to you as well. So we're going to start with Dr. Aaron Wernham. And as mentioned, I just wanted to make a couple of notes from his bio just as he gets started. I won't go through all of it. You can read most of it. But just to remind you that he's a family physician. So he is has experience, boots on the ground, knowing what it's like delivering care in very rural areas, and his work in Alaska, and is currently the CEO of the Montana HealthCare Foundation, and brings a lot of work to health policy now. And so I think it's a great opportunity for someone who has been in the trenches, who's provided care, to be so engaged in health policy. So we're going to go ahead and start with your presentation, Aaron, and then we'll go from there.
Thank you very much, Wade. Good morning, everyone. Hear me okay? I have spent a lot of time in this room in the last couple of weeks. How many of you were at the SUD Summit last week? Okay. Healthy communities? All right, well then I won't be repeating myself to everyone in the room at least. So good. So the Montana HealthCare Foundation, we're very glad to be here. Just I'll start with a little introduction or overview for those of you who don't know who we are. So we are an independent, private 501c3 private foundation. We are the state's first conversion foundation across the United States. There's a couple hundred of these. They are formed typically when a nonprofit health system, an insurer, or a hospital converts its tax status in some way. In this case, it was when Blue Cross and Blue Shield of Montana was sold to HCSC. So pursuant to that transaction, some of the proceeds or the revenue associated with the sale is used by the state to create this private independent foundation. I've worked with conversions around the country. Most of us do a combination of providing grants to support health innovations and doing a range of other work, from convening, which we've been doing an awful lot of this month, to providing direct technical assistance and expertise, to doing health policy analysis. I think it's one of the things that we found a gap as state and federal health policy over the last couple of years has become very complex, somewhat unpredictable. We felt like we could make some investments in providing good information, solid information to inform better decisions. So we just really started doing the health policy aspect of our work over the last year, and especially really over since the new year. Our goal is to provide solid, timely, fact-based information to help inform good decisions, and also to allow the health system to adapt effectively and as fast as is needed, depending on policy changes that come about. So this is just an overview, and again, urge you to visit our website where all of these reports are archived, and we'll be producing more as the need arises. We started in March with several reports. We looked at the impacts of repealing Medicaid expansion nationally on Montana. We looked at the role of Medicaid in treatment of substance use disorders, because this is really one of the most important potential benefits of the Medicaid expansion is providing for the first time regular source of coverage to allow the delivery system to treat this very important illness. We looked at the impact of an ACA repeal on American Indian people, because that's a very important population in Montana, and the ACA had a ton of special provisions for American Indians that are not, largely being addressed in the national debate, especially when things are moving quickly in Washington. Then when the House passed the American HealthCare Act, we tried to do a quick analysis just looking at the provisions in that bill as they might affect Montana, particularly focused on Medicaid. And then the Better Care Reconciliation Act that was considered by the Senate, we did an update of that same analysis for that bill. Again, we focused on Medicaid. And the reason for our focus on Medicaid partly is limited time and resources. We can't look at every issue for every bill. And we really have a very strong focus on at-risk populations. So Medicaid is obviously a lifeline for those Montanans that don't have another way to afford health insurance. So just a quick snapshot of Montana's Medicaid expansion, and this is a few updated numbers, but most of this is from the March report on the impacts of repealing Medicaid expansion in Montana. So we now have insured, and this is up to date for 2017, more than 80,000 Montanans under the Medicaid expansion. The vast majority of those have incomes below the federal poverty line. We know that in 2016, in the first year of the expansion, more than 50% of newly insured adults under Medicaid expansion accessed some preventive services. And I think that's just, we haven't had this for long enough to begin really tracking or measuring health outcomes, but we certainly know that the direction we want to be going with healthcare is for people to be showing up in primary care before they have a problem that requires ER care or hospitalization. So that seemed like an important trend. We know that in the first year, the state saved about $22 million through the Medicaid expansion in state budget. And we know that hospital uncompensated care decreased by about 25% in the first year. This is a pretty familiar graph, I think, for most of you. The uninsured rate in Montana has been declining and declined sharply after the Medicaid expansion, down to 7.4%, which is below the US average. So just a quick snapshot of the Medicaid program as it operates today. Traditionally, there's been, it's a federal-state partnership. There's a state match. In this case, we pay about 35% of every dollar spent, and the federal government pays 65%. That's before the expansion. Medicaid expansion created an enhanced match, so the state pays currently 5%. That phases down to a federal match of 90%, where the state would ultimately pay 10% in future years. For American Indian people, the federal match is 100%. It's a responsive program, so if for some reason Medicaid-related costs, health care needs were higher in the state in 1 year, the federal dollars come in at that enhanced match to meet the need, so if there were an epidemic or something like that. So just a few assumptions for the modeling that I'm going to show you on the next few slides. We assumed that the HELP Act would be reauthorized in 2019, so the figures that you'll see are based on that assumption. We assumed that the medical consumer price index would be 3.7% and that the regular consumer price index would be 2.4%. So this is just a look at Medicaid funding today in the state. It makes up about 38% of the federal funds that the state receives, and to pay for that, we pay about 10% of our state budget to bring in those federal dollars toward Medicaid. So the American HealthCare Act had a few Medicaid provisions. It would impose a per capita cap on health expenditures. That cap would be tied to the medical consumer price index, or for some groups, the CPI plus 1%. The bill would also eliminate funding for the Medicaid expansion in 2019, except that it would grandfather in people who are currently insured. So as we think about it, the goal is to get people healthier and back into the workforce. Anyone who cycles off of the program would be permanently unable to re-enter the Medicaid expansion population after 2019. The Better Care Reconciliation Act was very similar with some notable differences. The per capita cap was there, but it would be trended to the consumer price index, which, if you remember, was about 1.5 percentage points lower after 2025. And it phases out enhanced funding beginning in 2021 without that grandfathering. So these are the fiscal impacts. The American HealthCare Act would result between 2020 and 2026 in a loss of about 35% of our funding for the Medicaid program in the state federal dollars. That's about $4.6 billion of funding that we would lose for health care. Better Care Reconciliation Act, you see that steep drop in 2021. That's because of the assumption that as soon as the enhanced funding begins to phase out, the HELP Act actually requires that the state's expansion would be terminated unless lawmakers chose to do another bill. So you wouldn't see. You'd basically see the expansion end in 2021, and then after that, the further decline is the per capita cap. So again, that results in overall about a nearly 40% reduction in federal funding for the Medicaid program over that 5-year period. So just comparing, the bills would have had a similar impact if either of them had become law. We would have seen about 95% of people in the expansion population lose coverage by 2026 in the House version, the American Health Care Act. We would have seen 100% unless the state legislature chose to do something to up the state's contribution to the expansion population beginning in 2021. So I think that's Gene wanted us to do a quick snapshot. I think it's important to note neither of those bills became law. There have been other bills floated since. There are bills being floated currently as part of tax reform. The foundation, we're kind of doing our best to keep up, but these policy analyses are complicated and take a little bit of time. So it kind of depends how quickly Congress moves and what policies are proposed. We will certainly continue to engage in this. We think it's important to provide information for Montana about the impacts of federal legislation as well as any state proposals. So we'll be investing in this throughout 2017 and into 2018. I think we have a report in progress that would update our March report. We expect it out sometime later this winter. Just looking at with another full year of expansion, what can we say about the impacts of having Medicaid expansion to date, and what would it look like if we lost that bill? We'll also continue to look at the impacts at other options to address the healthcare needs in the state. I think to date we have not forayed into the private insurance market. We recognize that's an area in need of a lot of innovation and good ideas. So we'll be evaluating as a foundation whether there's a place for us to contribute there as well if we have a little bit more time to do that sort of analysis. So I think that's all I had. Just urge you to join the mailing list if you're interested in getting these reports. We'll certainly be, putting them out broadly to everybody that asks us to as we finish them. Thank you.
Great, thank you, Dr. Wyndham. While they're getting the next slide deck put together, I'll introduce Bryce Ward, who is the founder of ABMJ Consulting and the Associate Director at the Bureau of Business and Economic Research. He has a PhD from a little well-known school out in Boston at Harvard University, and I believe he's a duck, so with a BA in Economics and History from the University of Oregon. So Bryce has a lot of expertise in urban and regional economics, labor economics, health economics, you're going to see a theme here, public finance, social economics, real estate economics, environmental and natural resource economics, and statistics economics. So in general, he's an expert in economics. And really appreciate the opportunity to hear from Bryce this morning as he shares some of his thoughts with us.
Really, I'm probably an expert in nothing, right? That's what I think that resume suggests. When they asked me to be on this, they said, okay, we're going to do a panel on healthcare delivery. So I said, okay, well, what do I want to talk about healthcare delivery? Because, well, that's literally all of healthcare. So I asked myself two questions. So one, what kind of a framework can I provide as an economist? Because that's what we kind of try and do. We try and simplify the world down into simple little toys to think about healthcare. And then second, and more important, what can I do where I've already talked about so that I don't have to do any work because I'm lazy? So what you'll see is a little combination of the two. So when I teach students, and I do, we're doing research or whatever it is, I always say, well, you should always ask yourself, what's the ideal version of what you want to do, right? Because that helps you understand, well, that's what the best thing would be if, and this is what you're doing. If you understand the gap, you at least understand what's going wrong, right? So while Gene was telling you that all the great things that we're going to do, I'm going to take the opposite tack. They don't call me a dismal scientist for nothing. I'm going to tell you all the things that are wrong with, all the barriers to what we could imagine the ideal healthcare system is. And so first we have to kind of define that ideal. What is the ideal healthcare system, right? Because the reality is that nobody actually wants to go to the doctor, right? In fact, if you look at surveys about why people don't get care when they need it, buried in the other categories like text, and you'll go through it and it's like, I hate doctors. So that's a real thing. So what's the ideal healthcare system? The ideal healthcare system is this. You get shot and you pour water on it and you're all better, right? That's the dream, right? That's what we really want. We want healthcare that's like, oh, I don't feel good. Much better. This would be great technology if we had it. The problem, of course, with this documentary I watched when I was in 8th grade is that we had this technology, but there were some restrictions on it. You could only stay within this weird cave, and if you took it past someplace, the whole thing fell down. And so we lost the technology, got buried in a collapse. We haven't been able to replace it. So what do we do now instead of this miraculous technology? Well, oops, I hit some weird button. I don't know what I did. There we go. So how does the healthcare system actually produce health? Well, there's three parts to it. First, we've got to figure out what's wrong with you, right? What can go wrong and how do we fix it, right? So that's a research component. Then once we do with the research, we have the knowledge base. We have to ask ourselves, okay, well, what's wrong with you? Diagnosis. And then how do we fix you? Treatment, right? So that's what healthcare is, right? It's figure out what's wrong with people and then apply it to them by diagnosing them and treating them. So what can go wrong with that process? Well, there's three big areas. So first is that, look, we just don't know enough, right? Sometimes we just literally don't know what can go wrong with you, or more accurately, we don't know how to fix you. Sometimes even when you show up, we can't figure out what's wrong with you, right? There's an Office of Rare Diseases in the federal government, and I think there's 8,000 rare diseases, or maybe 16, I can't remember. There's a lot of rare diseases. And if you show up with a rare disease, odds are you might not get diagnosed, because diagnosis is hard. And we all know this individually, because if you ever Google your symptoms, you always have cancer. It's my head hurts. You have brain cancer. No. So, obviously we shouldn't be using Google to diagnose this. That's why you have to go to medical school. That's why Aaron had to spend all his time and money learning how to diagnose people, because it's hard. But then once we figure out what's wrong with you, we actually have to figure out how to match what's wrong with you with some form of treatment, right? And there's lots of different options for treatment, and sometimes they work, and maybe they work for some people, but they don't work for you. And that's also really hard. So obviously, how do we solve ignorance? Well, we need to keep doing research, right? And we do that in Montana, we do that across the country, we do that across the globe. That's just given, right? Is we have a long way to go in terms of what we still need to learn. But even where we kind of know what's wrong with you and we know how to treat it, sometimes our execution isn't perfect, right? And sometimes that's on the patient. We tell you, hey, if you want to get better, do this, but then the patient doesn't do it, right? In fact, recent estimates suggest that about $300 billion of healthcare in the United States, so 10% of healthcare spending, is spent as a result of people not doing what they were told to do, right? So patients suck. Yeah, we're not great. I don't like the doctor. The doctor told me to take these pills. I don't like pills. So I'll just suffer. Okay, and then you get worse and all sorts of problems there, right? So, but it's not just the patients that are problems. Some, we have problems on the delivery side where we know what's wrong with it, we know what we want to do, but we fail to achieve it, right? So that occurs in a couple of different ways. Sometimes we usually kind of bundle it under this coordination problem, right? So you take people, particularly complicated people, so that, people with multiple chronic conditions who drive most of our healthcare spending, frequently they have 4 doctors and 4 prescription medications that they're trying to balance. So the coordination problems are real, they're real challenging, and sometimes, tests get duplicated or information doesn't flow where it's supposed to help make the decision making, or, this person was supposed to do this, but they didn't really say it right, or, whatever. So there's coordination issues that are certainly part of our impediment to the deal, and those are just mistakes, right? So according to a recent study, medical errors are the 3rd leading cause of death in the United States. 200,000+ people, I think it's 250,000 people a year die as a result of medical errors. A survey of surgeons said, I think it's like 8% of surgeons admitted to the surveyor that they had made a major error within the last 6 months during a surgery. Right? So we still have we can do better in terms of just fixing mistakes and creating systems that kind of help minimize them. Then last, the thing I want to talk the most about is access. Right? So obviously, if I don't go see the doctor, I can never get the diagnosis or treatment piece of the delivery of healthcare. So why is it that people don't go see the doctor? Well, there's a large research literature on this, and it breaks it into kind of these 4 categories. The obvious one that we talk the most about is cost and coverage, right? So I don't have insurance, or I'm underinsured, so I don't go because I can't afford it, right? I'll talk more about that one in a second, but let's think through the other ones, because they actually are non-trivial, right? So the second one is just information. These are people who, they may have insurance, but they don't understand it. And therefore, they say, I'm not going to go because I don't want to show up to the doctor and end up with a bill, right? But even though I'm insured, but they don't understand it, because another survey that I saw recently, only 42% of Americans can accurately describe how a deductible works, right? So I have insurance, but I'm like, I don't know if I understand it. If I'm going to go to the doctor, I don't have any money to pay this bill, and so I'm just not going to go. Right? So there's an information problem, right? They don't know how their insurance works. They don't know, who to talk to. They don't know how to solve it, right? So that's another piece of our access barrier. Then on this is just kind of more generic access thing, which is I don't have transportation. In Montana, in a frontier state, it's too far and the weather is bad, right? This literally shows up in surveys of Montanans and why they don't get care. Again, in that other category was there was a snowstorm and I had to drive 2 hours, so I didn't go. Can't get an appointment, can't get off work, have other responsibilities. These are all non-trivial pieces of why people don't go get healthcare when they think they need it. And last, there's just this provider-rated deal, which is I don't like doctors. Or I had a bad experience. There's a barrier of communication. This particularly comes up with cultural and language barriers, right? So, if you're trying to match people who don't speak the same language or don't speak the same culture, there's some other barriers that tend to get in the way, right? But the big one, the main one that we talk about is cost and coverage. So let's dive into that, right? So how much does it matter, right? If I give people insurance, if I provide better insurance, do they actually get better care? Do they get better health outcomes? This has been a source of debate for a while. But how many people are in this bucket, right? So these are data all from before Medicaid expansion. Like I said, I'm lazy. I have this table. I sat down last night to do the 2016 update and was like, oh man, I didn't download the right data. And so I was like, whatever, this is what we go back to if we repeal it. So just think of it like that. If you look at this, and I broke it down by how rich or poor you are relative to 200% of the federal poverty line, and whether you're insured or not. And if you just go down to the bottom row and looked at 3 different things, did you not see a doctor due to cost? Do you have a personal physician? And have you had a checkup in the last 2 years, right? If you look at the bottom row, that's the number of people, the share of people within these little categories that have done all 3 of those things. So skipped there because of cost, don't have a personal physician, and haven't had a checkup in the last 2 years. 18% of people without insurance and who are less than 200% of the federal poverty line have done all 3 of those things. Only 1% of people who are insured and have incomes over the 200% of the federal poverty line have done all 3 of those things, right? So there's a big difference, whether you have income and whether you have insurance. But if you just look at kind of the top row, 42% of our uninsured, poor group didn't see the doctor because of cost. 54% have had no checkup in the last 2 years. These are big percentages of people. These are non-trivial shares of our population that clearly have a cost and coverage barrier to care. Just to show you that the other things are real too, right? So here's some of the other questions, these access things, couldn't get an appointment or too busy, didn't have transportation or just some other category. Between 14 and 20 and 30% of the groups report at least one of these things as well. And then they multiply if you kind of put the people who didn't say because of cost and then because of these things, it's about half cite both of them, right? So we have a non-trivial share of people who are, report having difficulty accessing healthcare. So how much does this matter? What would happen if we did a better job of giving people care and coverage? So the beauty of Medicaid expansion from the researcher perspective is when the Supreme Court said it was optional, they created this wonderful experiment for people like me to go and examine, right? Because you have these states that changed what they did, and we have these other states that didn't. So we have a control group, right? So we have the normal thing that's hard is like, we don't know what would happen if we didn't do this. Well, we have a bunch of states that didn't do it, so we can see what happened in those states. We can compare the changes that happened in the states that did it, and we can learn a lot about what's happened with cost of coverage. And there's just been, literally every week I get new studies of this, right? So what have we learned from this and from other stuff about what happens when you give people healthcare, right? So first thing is that, obviously when you give people insurance, their financial security gets a lot better. Just literally, the one that came out on Monday, suggests that in Medicaid expansion states, the near poor, kind of the Medicaid eligible, have avoided $3.6 billion in collections as a result of Medicaid expansion. And this has then, subsequently also improved their credit scores by an amount worth about $500 million a year, right? So financial security for the people who are eligible for Medicaid has been obviously drastically improved. And there's some spill-on benefits of that in terms of, other consumption benefits or whatever it is, right? So access to care and utilization, obviously when you give people insurance, you see that they utilize it, right? Aaron just mentioned that a little bit. We see that here. You're more likely to have a physician. You're more likely to receive certain care. More likely to receive surgical care. So that part of it works. We get the care. It takes a while to see the effects, but we're starting to see some of them. In terms of well-being and health access, so people, self-reported well-being, so if you ask people how well off are you or what's your health status, those have improved a lot for in Medicaid-eligible populations in Medicaid expansion states relative to non-expansion states. I just saw a paper this week 2 percentage point increase in smoking cessation rates relative in Medicaid expansion states. Saw a study last month about avoided cardiac problems and better cardiac results when you get care in Medicaid expansion states. So we're starting to see things that are actually, look, their health is improving in real ways and care outcomes are improving, but we're still too early to see a lot of stuff. Better mental health. And when it comes to mortality, the evidence is a little mixed. The strongest evidence we have comes from looking at Romney Care, because it was long enough ago. And if you compared places that, poor people that lived on the border of Massachusetts to, say, Rhode Island or Vermont or New Hampshire or Connecticut, there was a substantial decrease in mortality amongst the poor populations in Massachusetts when they passed Romney Care, right? So we have some evidence that it really does matter for the big thing, which is mortality, right? So that's what access to care does to the individuals who get the care. So who are these people? Right? So there's a lot of talk when we talk about Medicaid expansion about kind of they're some sort of undeserving group, right? We shouldn't be caring for these people, right? So, well, who are they, right? So using national data, who are they? Well, about 48% of them are kind of not able-bodied, right? They have some sort of permanent disability, some other mental or physical health problem, or they list themselves as being in fair or poor health. Now, I didn't break this out. Many of those people still work. They still have jobs. But, at least almost half of them nationwide tend to be in relatively poor health. So amongst the people who don't have, some obvious health problem, 62% are working or in school, so 32% of the overall population. 6% are still looking for work, 10% are caregivers for somebody else, and only 4% are able-bodied and not working, in kind of this weird category. So that's who's getting these benefits, just so we, have some baseline about that's who's benefiting from all those things that we just talked about. But it's not just these people that benefit, right? So Aaron just told you about the billions of dollars that the federal government transfers to our state. I want to put that in a little context, right? So he showed you, I think what number was 5.6 billion was one of those things over a 6-year period. Right, so that's slightly less than $1 billion a year transferred to Montana, right? GDP of Montana is $45 billion a year. Right? So that's almost 1% loss to GDP. So what would happen if we took 1% of our GDP? Well, that's not good for our economy. It's certainly not good for our healthcare sector, right? So what's happened with Medicaid expansion to the healthcare sector? Not in Montana, but again, nationally. So obviously, Aaron just told you about uncompensated care. Here's a different version of it. You can see the lines when they're parallel. That's before Medicaid expansion. And then, what happened to the black line? Well, those are states that expanded Medicaid, and this is the decline in uncompensated care on average. Not much happened in the other states. Now this is looking at profit margins, just focused on the two red lines. I know it's hard to read, but the red line, the bubble on the left, that's rural hospitals, and those are the increases in their profit margins. And the second one is small hospitals, right? So disproportionately, the profitability from Medicaid expansion, the improvement in healthcare is in small and rural, right? We have those in Montana. Right? And in fact, if we look at where rural hospitals have closed, right? So all the dots on this map is where a rural hospital closed in the past several years. If you'll note, the blue states are non-Medicaid expansion states. You'll notice that most of the dots are in those states. Right? Now, I haven't put those together. I'm working on a project to try and put them together. But certainly, to the naked eye, it suggests that there's a relationship between Medicaid expansion and rural hospital health and rural hospital capacity, which then affects everybody, right? That goes back to access, not just for people who have Medicaid, but for anybody who lives near in those communities, right? So with that, I will stop and pass it back to Wade.
Thank you, Bryce. Now we'll hear from Brenda Solorzano. Over the last 12 years, Brenda has been a leader in the philanthropic world. In addition to her philanthropic background, she has extensive experience in working on health policy issues, particularly on topics related to health coverage, the healthcare safety net, and public health issues affecting vulnerable populations. So we'll hear from Brenda now.
Good morning. I'm going to start off by saying that even though I've worked primarily in the healthcare delivery space, the work we're going to be doing at Headwaters is much broader than that, because healthcare is more than just the delivery space. Healthcare happens everywhere. It happens where we work, where we play, where we live, and that's part of what we're interested in addressing at Headwaters. Just waiting for the slides here. Just yesterday, I was in Pittsburgh with a group of funders, and health was happening there. They weren't health funders. They were funders that fund on a variety of different issues. And throughout the conference, they kept stopping and having us do squats and jumping jacks, which I think is a great example of how even funders are recognizing that health happens everywhere. All right. So I want to start off with sharing a little bit about the Headwaters Health Foundation, and Aaron did a great explanation of what health conversion foundations are. We are the second health conversion that has come online here in Montana. I like to think of myself as the little sister foundation to the Montana Healthcare Foundation. And where the resources come for Headwaters are out of the sale of Community Hospital in Missoula. That sale generated $100 million, which has become the endowment of the foundation. It's going to translate to roughly between $3 and $5 million worth of annual charitable giving by our foundation. We are not going to be statewide. We are going to have a focus on Western Montana, and that's because that is the geographic footprint of Community Hospital. So the 15 most western counties are going to be within our service region, and that's the space that we're going to be working in. We are governed by a board of trustees that are 9 members, and I just have this slide right now because I want to make a pitch. We have 2 transitions that happened over the last month. We're looking for board members. If you're interested in serving or know someone who is, please see me. You can also visit our website for information on that. So when I think about philanthropy, I think about what is it that philanthropy can do in partnership with key stakeholders, with grantees, with elected officials, with business community, with the healthcare delivery system. And really, our foundation is going to be interested in having a broader approach than just grant making. we're interested in really working on what does it take to create healthy communities. And that goes, as I said before, much broader than just the healthcare delivery system. How do we think about bringing unique bedfellows together in collaborations to improve overall health and well-being in communities across western Montana? What are upstream approaches? So I'm going to be interested in getting outside of the healthcare delivery system and thinking about what interventions, innovations, pilots, demonstrations are going to be possible to show that we can improve the health and well-being so that we don't bankrupt the healthcare delivery system. And then really thinking about systems change approach. You know, the work that is going to have to happen in this state and across the country has to be really focused on systems change, because if we don't change the systems and the way they're financed and the way that they're operated, we're really never going to get to true better health outcomes. So when I think about the toolkit that a foundation has, I think Aaron has already demonstrated the application of this toolkit in western Montana, and it's something that I'm very interested in seeing Headwaters also do. So really thinking about how you can play in the policy space, in the research space, convenings, collaborations. And that's the approach that we also are going to have at Headwaters. So I'm going to start sharing some data charts, and they're far too small for you to see. You're probably going to go see your eye doctor after this. But it's data that I was interested in looking at when I came to western Montana, and I had it broken down by the 15 counties that we're going to be working on, because our work is going to be at the local level within each of those counties. And this first chart is just a highlight of region demographics, and there's a number of different data pieces in here. But the piece that I want to call out for you is that this data shows that Montana's population is having incremental growth. But there are significant declines in overall population in rural counties. There's also rising healthcare housing costs across Montana, which has become a significant issue for many of the families that live in our region. Another thing that's worth calling out is that American Indians live across all counties in western Montana. They're not just where the reservations are located. And we're also seeing a decreasing workforce that creates in the healthcare delivery system access challenges and also a tax base erosion, which is a significant problem for a state like Montana. The other thing, actually I'm going to, this is the population one. Let me go to the economics data slide. The thing that I call out that the pink boxes show is that in many of the counties that are going to be our target counties, we have higher than average poverty rates than what Montana has. So Montana is a 15.4% poverty rate, and each of those counties that are highlighted in pink have higher than that rate. In the insurance space, the Medicaid expansion, as Aaron said, has reduced the number of people that are uninsured. It's been a 12% drop. I think it's worth calling out that it's double digits as a result of the Medicaid expansion here in Montana. Yeah, actually, I'm going to go back here. The main point that I want to pull out of this data slide is that a significant percentage of Montanans are covered by government programs. It's almost half of the population in the state is either covered by Medicaid, Medicare, or are uninsured. And I think that has significant implications for the work that you all do and the work that the foundation is going to be doing. I like showing this slide because it tells the story of the health disparities that exist between American Indians in Montana and the rest of the population. You can see that American Indians tend to die a generation younger, almost 20 years on average relative to the rest of the Montana population. This is a slide that captures mental health by each of our counties, and a couple of things that I'll call out here is that the U.S. median is 3.5 days. People are reporting unhealthy days over the last 30 days. The Montana average is 3.3, so it's actually a little bit lower than the national average. But in our region in western Montana, 10 of our counties report higher than the U.S. median and higher than the Montana average. On alcohol and substance abuse data, I think we all have heard about the opioid epidemic and the meth problems that exist here in western Montana. But one thing that I want to call out is the high rates of alcohol use. So in particular, heavy drinking. In the U.S. is reported, 21% of people report heavy drinking in the last 30 days. In Montana, it's 19%, so again, a little lower than the national average. But in western Montana, 9 of our counties report higher rates of heavy drinking. Youth suicides, as you all know, is a significant challenge here in Montana. This slide shows that in the time period between January 2014 and the end of 2015, there were 20 suicides in Montana, which probably doesn't feel like a lot, but it's probably 27 too many. And I think one thing that's worth calling out is that we're looking at suicides in 11, 12, 13-year-olds. So it's not just the adults or the teens, it's kids. Looking at childhood wellness measures, Montana ranks in the bottom half of all states across many of these measures. Ones that I'll call out in specific are Montana ranks below on well child visits, on the consumption of alcohol by pregnant mothers, on immunization rates, and on suicide. So this is telling a significant story that will have long-term impacts on the work that you do and the services you provide. On health behaviors, Montana meets or exceeds, western Montana meets or exceeds the overall Montana average on obesity, food access, lack of exercise, and alcohol-impaired driving deaths. So again, lots of different challenges in terms of health behaviors. So this is the data that I was looking at when I first came to Montana 6 months ago. The other thing I did is, because I'm not from Montana, I'm new here, I've been here about 6 months. Actually, I think it's almost 7 months now. I wanted to have conversations with people in western Montana and hear from them directly, people on the ground. What are the big health issues and challenges that you see in your communities? So in the first 3 months that I was here, I drove up and down western Montana and talked to roughly about 500 different people. And this pie chart just shows characterizations of the different types of people. Again, remember that I was interested in not only talking to healthcare providers, I included them in the group of people that I connected with, but I also wanted to talk to people that were in the food security work, who were doing homelessness work, who were working with nonprofit leaders that were addressing economic health and well-being of communities. Also interested in talking to policymakers, both at the local and at the state level, providers across a wide variety of range. The question I asked these individuals was, if you were in our shoes and you wanted us to address the major issue or population that you see as a challenge in western Montana, what would you do? And I know that some of you were part of these conversations that I had that are in the room. And this is a synopsis of what I heard when I asked people across western Montana what they thought were the biggest issues. By far, the one that was most frequently mentioned was behavioral health and the challenges that that creates in communities in western Montana. The second is social determinants of health. And within that, issues of housing, nutrition, air quality, economic development, childhood development, family resiliency. So a lot of different issues captured in that particular area. And then two populations that were mentioned as ones that needed particular attention are American Indian communities, and I think that's given the disparities that you see in the data, and children. The fact that children in Montana don't have the same kind of opportunities that children in other states in this country do, and a desire to really make a better Western Montana for them. So that actually led us to conversations with the board. When we look at the data that I shared with you, and there's a lot more if anybody's interested, I'm happy to share. And when you listen to what people on the ground across Western Montana are saying, the board said we need to focus on those issues that are right in front of us, creating lots of challenges that are actually creating expenses for all the services that you all provide to your employees and your beneficiaries. So we're going to be working on issues of behavioral health and social determinants of health. And in particular in the behavioral health space, we're going to be interested in looking at substance abuse, with alcohol being included in that, taking an approach around prevention, so really thinking holistically about how we address the issue across an entire spectrum and not just at the service delivery level. Thinking about ACEs and how we help providers learn about ACEs, which is adverse childhood experiences, screen and diagnose and provide interventions. Thinking about, again, in that particular setting of ACEs, really an upstream lens and approach. And then in the social determinants of health space, we're going to be really interested in looking at housing, knowing that if you don't have housing, you have lots of reasons for why your health outcomes are much poorer than people who are successfully housed. Looking at children and family as a particular focus, especially around building resiliency and trying to break the cycle of poverty and the challenges that created when there is that cycle, and food security. So timeline, this has been fun because I've gotten to learn a lot about Montana, and I've gotten to travel and look at a lot of data, and I've been at all these conferences with Erin and learning even more. But I'm really getting antsy about actually getting out and doing the work. So we are going to be having a strategic retreat with our board later this year, so I guess next month. And we're going to finalize our strategic plan and get ready to start making grants in the spring of 2018. The reason that it's important for me to share that timeline with all of you in this room is I see all of you as potential partners in the work that we're going to be doing in Western Montana. I can't imagine that the work that needs to happen to really improve the overall health and well-being of these communities being done without employers, without the insurance companies, without providers. It has to be a partnership if we're really going to improve the overall health outcomes of everyone that lives in this state. So really excited to be here. Thank you for listening to me, and look forward to partnership.
Can we get these on? Let's see. Are these on? They're not. Can you guys hear us? Sort of. Yeah. Okay. So now we're going to shift a little bit in our conversation, go through some questions, and then we'll also open it up to you. Before I do that, we actually have somebody from the business industry with us to my left that I would like to introduce, and I will give Ben just a chance here in a second to tell you a little bit more about his organization. Ben is the CEO of Consumer Direct and was appointed President and Chief Officer of the family of companies for Consumer Direct in October of 2012. In his unique professional career with Consumer Direct, Ben has performed tasks at every level available in the company. One of the things that I thought interesting about reading his bio is that he's probably just about done it all in the organization as he has grown his career and has seen delivery from various different perspectives. He's initiated comprehensive compliance and quality improvement initiatives in his organization, and has increased customer service and worked on accountability as well. So what I'd like Ben to do, and an interesting thing about him, by the way, is he spent a couple of years with the Peace Corps in Tonga, so that kind of gives an interesting perspective, I think, to life for those who have spent time doing that kind of work. So Ben, if you'd just take a minute and tell us a little bit more about Consumer Direct, what services that you provide in that space, that would be great.
Sure. Thanks. Again, I'm Ben. I'm from Consumer Direct Care Network. Try to go by Consumer Direct Care Network because the Consumer Direct tends to confuse folks about what we do. Our company began in Missoula, Montana as Nightingale Nursing and Caregiving. And then we took on the consumer-directed model of service, and that's a service where we train folks that are receiving care to take more of the accountability and management responsibility of the people, the caregivers, workers that come into their home. Hence, consumer direct, taking on that model, and that is consistent name of programs that we service across the country. So we've grown from a small nursing agency in Missoula. Nightingale Nursing had about 40 employees when the current owners purchased it in 1996, and now we service 14 different states. We serve about 16,000 people and pay roughly 25,000 people across the country. So it's grown to be a very large organization based in Missoula, but we see ourselves as an innovative, low-cost model of service for people. As you mentioned, those 45% or so of folks that are on long-term care, those people that are not able-bodied in the Medicaid space. So, for instance, our work is about 97–98% funded by Medicaid, and we do everything from that personal care model, people that need activities of daily living and instrumental activities of daily living is our primary focus, but we also do behavioral health, Medicare, home health, hospice, and again, that multiple models of the personal care being traditional models where we have caregivers that we send to homes, but really we try to direct people on how they can take more of an active role in their care so that you are more engaged as a client, and typically it drives down cost and increases satisfaction. So we've been doing that model and pushing it across the country, and been really successful, and a lot of fun to see a lot of the increases in happiness of people that can stay in their homes and healthy. So that's
great. Thank you, Ben. Question, and I'll start with you. And what I'd like to do is just kind of open it up to the four of you. But we'll start with Ben here, and then the others can chime in. You can see that we have a researcher, and then we have folks working on the foundation side and policy, and then also in industry, if you will. And so I'm just curious if you might share with the group some of the challenges that you have. Each of your work is important in the healthcare space. And I'm wondering, as you look look at the current situation, but then also looking ahead the next couple of years, what are some of the challenges that you feel in your particular space, whether it's research or whether it's delivering care? What are some of the challenges that you see facing you to get your work done, or for your organization to get your work done going forward? And we'll start with you, Ben.
So I go back to the access word that I think we deal with a lot, and because we're dealing primarily with Medicaid, a lot of that has to do with funding, but also trying to afford folks that choose to be in non-traditional environments of where you would receive care, and try to get them the access to what they need. So, for instance, rural communities, and so for us, where we try to find workers in particular to go into rural communities is exceedingly difficult, in particular nurses. The example that I throw out there current is the reimbursement rate we receive for Medicaid nursing and in-home nursing. The rate we receive as a company is equal to the amount in Montana that hospitals can pay those nurses. So to compete for those nurses in any community is exceedingly difficult for an in-home care. And obviously they're different. They're very different models of service, but trying to get those kind of nurses into homes is challenging. And then across the country, as we see personal care workers who make anywhere from $9 an hour to $16 an hour, trying to compete with other industries like fast food, retail, things like that. So those entry-level caregiving jobs become really hard to staff, and for anyone to see that as a career is particularly hard. I started as a caregiver with this company, so starting at $8.50 an hour, but feeling that I'm the exception to that rule, but understanding what it means to do that work and how important it is, how hard it is to do the work, and so to talk someone into choosing that line of work versus something like fast food or retail is extremely hard. So trying to push harder for the acknowledgement that this is worthwhile work. It's helping people that are particularly in the long-term care sector to stay with the job, keeping people happy and healthy in their homes. And then as we as a company see ourselves as innovators, trying to find new models to find people to go to the even rural areas of the country. Again, the self-directed model that we support so much is workers that traditionally wouldn't do that work would do it for someone that they know and they care for. So a neighbor, a friend, family member who's willing to go into a home, and helping people in that taxpayers understand that this is work. Even though it's a family member, it's still worthwhile to send someone into the home. Having them do that work is also important. So I see access and staff as our major challenges and the things that we're always trying to overcome.
Great, thank you. Brenda?
So I see lots of different challenges. Access, the vulnerability of the Medicaid expansion in Montana, the rural challenges that are created by a state that spread out so far and wide. But the one thing I would say is going to be the most significant challenge for us is the lack of momentum around shifting the way that the healthcare delivery system is financed and what it rewards. So if we're really going to get upstream, if we're really going to create partnerships between the healthcare delivery system and the people that are working in housing and behavioral health, substance abuse, child care, we're going to have to think about a different approach to incentivize those collaborations, to evaluate and pilot different partnerships than what we see today. And this country's healthcare delivery system is moving in that direction. And I'm still trying to understand where Montana is along that trajectory. But I do know that significant challenges will exist because of the limitations of how healthcare is paid for here in Montana.
Great, thank you.
Well, I just gave a whole presentation about everything that's wrong. But I think the thing I didn't talk about is, so we spend $3.2 trillion a year as a country on healthcare. Right? It's almost 20% of our total output is in healthcare. That's a lot of money. We don't get great outcomes for all that money, right? So kind of speaking in the same range is, the question for us is how do we figure out how to better use that $3.2 trillion to get more health, right? And that might be doing more. I do research on, people with long-term disabilities and how do we get them to participate? How do we get them out of their house? And, we do research on, okay, well, how much can we do in terms of improving their physical capacity? How much of this is literally just their house, right? How much does their house create a barrier, right? So we need to learn about these kinds of things, and we need to learn about how do we create health more efficiently, and then try and reward the stuff that gets the health done. We have a long way to go before we're going to ever find something that works enough that is worth doing because it's going to piss a lot of people off. That's really how it works is, essentially what we're saying is take money from those people and give it to these people. Well, those people don't like giving up money. And so you have to figure out ways to say, look, this is totally worth it, sorry. But that's where we're not there yet, right? We haven't got to the point of saying, yeah, no, sorry. We're starting to test it, and when we do it, people get mad. I think it's half of primary care physicians hate accountable care organizations and all the care coordination stuff, right? Payment model changes, they hate EMRs, all the stuff that we're like, oh, this will make things better. There's pushback, and so we have to do more to kind of understand, well, this really does work, it really does make things better, and then we have to take the money and redirect it there and kind of just say, we feel your pain, but this is worth it for us. And that's a hard thing to do, but that's the adult thing to do, so we have to do more of that adult stuff.
Bryce, do you think, just to follow up on that, do you think that there is, are we asking the right questions from a research standpoint, from an economics standpoint? Do you think that what you're seeing nationally, that we are asking the right questions and that we're beginning to get data together that's going to be meaningful in that regard?
Yeah, the healthcare research industry is enormous. There's like the Kaiser Family Foundation, Robert Wood Johnson Foundation, there's a bunch of stuff, there's a bunch of capacity. Whenever we do anything, we study the heck out of it. We try and encourage people to do it in ways that allow us to actually study it, so there's lots of research, anytime anybody asks me a question, I just go, okay, Google Scholar, and an hour later, I've got a pretty good understanding of what we know, right? The challenge, of course, is that it's not always clear cut, right? This thing, there's not like, this is just magic, and we don't get to test it in ways, and sometimes you'll work one place, then you'll find another study that works, doesn't work, so we have a lot of work to do. We think these things work, we think a lot of stuff, and we're trying lots of different stuff, but, we need to probably increase the rate at which we experiment and learn and, kind of use the kind of lean startup kind of model in healthcare. But the problem is that there's so much entrenched interest in healthcare. It's hard to experiment. It's hard to get an experiment done. It's hard to get it, and then just like you do, doing healthcare policy research is just like clinical trial research, right? Well, what's the problem with clinical trial research? You have to get people to participate in the clinical trial, right? Which sometimes they don't want to do. And so we have to get health systems to participate in research and learn from it, knowing that convincing that this might not work. You're going to go through this pain, and at the end of it, we may kind of do our fancy study and come back and be like, oh, well, that didn't work, right? Because, this isn't in the healthcare space, but just yesterday. So I'm an urban economist, so you read my long list of things. So as an urban economist, since I was an undergraduate, my very first, probably the third thing I learned about urban economics was, you want to fix traffic congestion? Price roads, right? Make people pay to drive on roads, right? That's the magic solution that economists do, right? Well, some enterprising graduate student went to India and ran an experiment where it was cheap to do and basically overturned this and basically has argued, it was one paper, so I won't say it's overturned it, but it certainly forced me to update my beliefs, is that the welfare gains in terms of time are not sufficient to compensate for the fact that how do you get that time is you get people to change their flexible, right? So basically if I don't have money, I choose not to drive at the busy time and whatever it is, well, that's a cost, right? That cost, it turns out, is actually bigger than the time savings that we get, right? So, we've been saying do this, but sometimes it doesn't work. Yeah. And, so it's hard.
Great, thank you. Dr. Wernham, challenges ahead for you and your organization.
So I think I'll probably echo a lot of what my colleagues have said, but I think that the real challenge we have is to improve the performance of the delivery system to get better health outcomes for the investments that we make, and not just investments in health, but we've been looking, for example, a lot recently at substance use disorders where the costs accrue to the corrections system, the justice system, the social service, child welfare systems. And how are we going to deliver better outcomes? Is it a matter of not having enough money now that we have a Medicaid expansion that pays for treatment? Or is it a matter of not necessarily delivering the right interventions? I think if you break this down, take it to a much simpler issue of providing immunizations. We do a pretty good job. We've got a pretty good share of the population immunized. It's a simple intervention. It's something that you can deliver relatively easily. But we're still not perfect there. So if you look at some of the big health challenges in Montana, like behavioral health issues, you can look nationally and find examples where systems are actually delivering 50% reductions in recidivism, better mental health outcomes, better substance use treatment outcomes. But how do you actually build the system in the state around that and deliver those better outcomes statewide? I think that's something we're really focused on right now. I think the other challenge is uncertainty. Look, I think Medicaid expansion I view as a little bit akin to getting financing for the skyscraper you'd like to build. Now you have to build the thing. We have to build a delivery system now that we have financing to pay for it. And really I'm talking largely about a system that can deliver better care and better outcomes for behavioral health issues, which have been historically very underfunded when people didn't have coverage. So it's going to take time, and trying to get the healthcare system to reorient itself now that we've got a payment method when there's uncertainty about how long that's going to go on, what's going to happen at federal level, what's going to happen at the state level. I think that's a challenge. So dealing with that uncertainty is kind of issue number 2 for us.
Great, thank you. Kind of following on the theme around collaboration, and we'll keep it with you right now, Dr. Wernham. I'm curious, and because Brenda had mentioned this too, and we've heard the theme of where we can collaborate from a provider's perspective. What do you, or how do you feel that the collaboration is going with providers across the state? those that are actually delivering the care? Are you seeing them come to the table with you in these issues? Are you seeing concerns that are coming your way from them? But maybe just touch on, as a physician and someone as a caregiver, can you kind of share some thoughts about that?
So I think one of our main kind of areas of focus as a foundation is really partnerships. When you look, especially in rural areas where you may have a community health center and a mental health center and a hospital, all of whom are struggling with, you know, the funding issues as well as recruiting and hiring staff. We really do focus on trying to inspire and support new collaborations that would lead to efficiencies in operations, better, more effective use of staff, and I think we're finding tremendous interest in that. I think collaborations then more broadly. So again, and I'll talk more this afternoon at you about behavioral health particularly, but I think, you know, we are also seeing a lot of interest in what I'll say is, you know, reuniting the head with the neck and the body, which is, you know, stopping this fragmented care where if you have a complex set of medical issues and behavioral health issues, you have to go to 3 or 4 different providers, and actually beginning to try to create a situation where it's easy for people to get all the care they need in one place at one time. So I do think that partnerships are a huge part of the solution. And then, you know, we're seeing there's other health partners that haven't traditionally worked necessarily with healthcare. So we've worked a lot with county and tribal health departments that are now beginning to form partnerships with hospitals and healthcare systems to address the upstream determinants of health. I think, and even, you know, again, doing some work on health and housing, like Brenda mentioned. I think this is really in some ways where the money is if we want to be improving outcomes, and it's a big focus for us.
Great, thank you. And Brenda, maybe you could add to that too. You made the comment about collaborating at the local level. As you know, we look out across the state and have local community organizations, et cetera. Are there particular opportunities that you see for that local connection? Just particular organizations that you see locally that can help in this effort?
Yeah, so one of the things we've been doing is having local community meetings in every county. We're almost done with them. We have one more on Monday. And one of the things that has been interesting as we've invited communities to come to the table is that the local business chamber is there at these community meetings. The school superintendents have been coming. The local hot CEO of the hospitals, the leaders of community clinics. So there is a broad spectrum of folks that I'm seeing at the local level that are very interested in figuring out how they can all come together, because they all really care about the health and well-being of their community. And I think that bodes really well for potential collaborations. On the flip side, this is a state that is resource poor. And with budget cuts coming down the pike, nonprofits, health providers scratching and fighting for every last dollar, it creates challenges around people protecting their piece of the pie, and whether or not they're going to be willing to come to the table to collaborate with the possibility that their piece of the pie might get cut or spread out to other players in a collaboration.
Yeah, you bet, Ben, please.
I'll just jump in on some of my experience on trying to implement some of those things, being someone that's kind of downstream, really far downstream in my opinion. We get treated that way at least sometimes. But coming up and trying to say, how do we put some of this, how do we implement some of these things, how can we as a business push ahead? Knowing that there is the common sense of like just protect what you have, and saying, hey, how can we be proactive and offer solutions to a state or to a community or to an insurance agency, MCO, whatever it might be, and say we have ideas about how we can leverage our workforce, our expertise, how the money flows through us to improve the outcomes for people, because there is that segmented part of someone that's receiving Medicaid in a long-term capacity, and how that translates over to their use of hospitals or clinics or wherever that might be. How can we, as an agency that has people going into homes every day, provide a link to what's happening in a home and what's happening to a person in real time, so they don't end up with some catastrophic event. And it's interesting when we start to present those ideas as like, we want to implement this, let us help you, let's take on some risk, all those sorts of things that come along with the Affordable Care Act and the pushes that you see in the industry. but it feels as if everyone is bombarded with those ideas, or they have their own ideas, or they feel it's not quite a big enough mover. So it's interesting as an agency wanting to do these things and trying to jump in and be someone that can be innovative and a leader in that respect, but get someone very excited and then have it get to a certain point and then just kind of fade. And I see that over and over and over again. So I'm optimistic that one of these days it will latch on and it will go ahead. But so far it's been challenging to do these collaborations and move them ahead.
The workspace that we're in is rather diverse in the services that we all provide, and getting us to collaborate and work together is going to be important for all of us as we move forward. And I know from a health systems perspective, as we look at the health and well-being of the community, it reaches well beyond the walls of a hospital or a doctor's office, as you're mentioning, and gets into transportation issues. It gets into economic issues about the really the strength and the well-being of the community, because we now know that all these things tie back to one's health. Just one last one that I'll maybe have you address, Ben. Just, you had mentioned in some of the challenges really about getting talent, getting people, human resources together to be able to deliver as you see things going forward. Are there particular things that either your organization is doing or that you're seeing others in your space that are trying to attract talent to here in Montana or build folks within your workforce?
Yeah, so if I think of, we were just discussing this briefly earlier, but when we think about those administrative professional positions, I think we have a good track record of showing people what it means to be in Montana. And I think Montana is attractive as a state. I make jokes all the time when I go travel around the country of it's fun to say you're from Montana because everyone has a great impression of Montana. If you say you're typically one of the Northeast states, you get a little bit more of a pushback for some reason. California has a little bit of that going for it too. But anyway, Montana is a great place, and so we can sell that for talent and people taking on a lifestyle in that world. But when you get further down the line to those people that are delivering service, someone that has more of a skilled perspective training, we can attract them in some cases, but it's harder. It's harder to go beyond just wages and benefits once you get past a certain level of comfort level of having your needs met. It's that living wage question of where's the break, and can you use that to attract people into the industry. So I think it's challenging. I don't have a magic bullet solution for how to push people that way beyond hey, if you choose a different model of service, if someone that you're receiving care from is willing to try something new, either, like I mentioned, the self-directed question for us, or some of these other innovative other programs to add a little bit of extra incentive to somebody. Beyond that, it's hard to push.
Yeah, it's that balancing of trying to get folks coming from out of state, but also to provide training and development for the folks that we have within the state. At St. Peter's, we currently have, I think as of yesterday, about 140 open positions. And so trying to find, we come up with these great solutions on how to deliver care, how to collaborate, and at the end of the day, we need people to deliver on that. And I know that there's some conversation that will be taking place later about that. And those factors tie all the way back through each one of us. What I'd like to do, we have about 10 minutes left, and so I would like to open up the floor to all of you for questions that you may have of any of the panelists here. The work that they're doing, or any challenges or questions that you may want to throw their way. So I know we have, do we have a microphone that we're going to pass for this as well? Oh, right here. Okay, so could you, we have a question right here in front. Now's your opportunity to make them sweat, so let's make them work on this one.
I have a question, a comment, and then I guess a question. When we look at our healthcare system and the revamping of it, as we've been talking about since I've started in this career over 25 years ago, but we seem to be reinventing some of the things around the hospital system because that's where the money is. So now all of a sudden we're seeing public health kind of being reinvented through the hospital system, or even human services through the hospital system. Why aren't we looking more at integrating with the public health system, or integrating with the human services system, instead of reinventing the same thing around that? I agree our public health system and our are underfunded and are struggling themselves, but it seems like it would be much more efficient to rebuild that up and integrate that than to try to build a whole new system around a hospital.
So Reed Humphreys, who's the Dean of the Health and Medicine Program, Ellen Leahy, who's the County Health Director at Missoula, and Tony Ward, who's the Director of our Public Health School, and we wrote a proposal to do exactly that in Missoula. We're still trying to find money. But that was the idea. The idea was to say, well, we have these new doctoral students in public health, like let's use them as labor pools to kind of try and help integrate and do the social determinants, figure out how to do it all. The challenge is we still haven't fully created the incentive structure to get all the money to flow in to say, yeah, well, let's try this out. And that's one of those experiments that, maybe it works, maybe it doesn't, but, you still have to find, quote unquote, the investors to kind of put up the money to say, yeah, let's try and integrate all of this. I know. But she's new. She hasn't been here that long. Trust me, she's heard it, I'm sure.
The hospitals have to do a community needs-based and community, I'm going blank on, yes. They have their money that they have to put out there through the ACA and the IRS if they're continuing to do that. That might be one creative way of using some of that money instead of for a health fair.
No, it's certainly, it's all linked to that. It's all builds from that.
If I can jump in here and say that that's exactly the kind of thing that Headwaters is going to be interested in funding and trying out, taking risks, evaluating, learning, and figuring out how you spread those things that work. I think the other thing that's worth noting is I don't think public health has as many invested advocates and key players in the legislature at the state and the federal level. And so when cuts are going to be made, there's nobody jumping up and down. I've been in counties in Montana where the local health department was completely defunded. And I think that's a problem and a challenge that faces. And there is desire to do that, and I think it would be interesting to try to see if you could test something out in a rural county in partnership with the health department and the local service delivery.
Just a comment from a health system perspective. I've seen this done in several different markets, and where there's collaboration with the health system and also with the public health. And there's no question as we look forward, even as Bryce was mentioning, we've got to try new and different ideas. And sometimes even, capitation's back just with a different flavor now, right, from the 90s. And so I think we try things, they don't work, we learn about why they don't work, and then we come back, we improve them and try again. And so hopefully in one of these cycles, as you're mentioning, we're going to get it right. We'll get the right people to the table. I think from my perspective as running a health system, I think we recognize that there are spaces that we perform very well in and other spaces where we don't have the level of expertise that we like. And so this is where that collaboration becomes very helpful to us. And we've had a lot of conversations internally about opportunities that we have to partner, to innovate, and work with different agencies and lean on their expertise to be able to try to make a bigger dent, if you will, in moving things forward.
I think it's an essential question. We again, Bryce made the point, $3.2 or $3.3 trillion a year on health now, and we don't have the health statistics that you would hope to for that. But we are also still largely as purchasers of healthcare, purchasing services rather than purchasing outcomes. I think the more that we figure out ways to creatively pay for what we really want to get out of the health system, the more we'll see innovation that brings public health, kind of back into the fold as something that is worth paying for, because we know that public health is capable of delivering better health outcomes. At a local level, we invest a lot, like I said, in partnerships, and have been really encouraged to see now a lot of hospitals starting to work with health departments on doing joint community health assessments. And I think that will begin to drive then partnerships to, strategically to address the health needs that are identified.
Still have a few minutes. I think there was another great, yes.
As continuing education specialist for Montana Nurses Association, I just wanted to do a comment of that there is just 50% of our nurses in Montana practice in hospitals, and that an opportunity for adherence and coordination with health delivery and prevention is a look at cultural competence. And if you look at the stats, only 1% of our Native Americans are represented in the registered nursing community. And we all know that people adhere to their health care if they trust the deliverer. And I think that is one place we could look at foundations helping with the Blackfoot Community College and the other colleges that are trying to increase the registered nurses that are educated from the Native American perspective. It's also Hispanics and Blacks. They're a really low percentage of RNs. And so education is the key, I think, of opportunity for improvement. Thanks.
Great, thank you. Other questions?
Well, and I will just respond to that by saying, I mean, and thank you for the comment. And I think, you know, the American Indian health delivery system is, you know, operates, you know, separately and often without a lot of partnership or support from the rest of the health system in the state. I think this is a major area of investment for Montana HealthCare Foundation, one of our 3 main focus areas. And in fact, we are working with Blackfeet Community College and a couple of the others. You know, I think funding workforce development is a challenging thing for foundations because it requires often stable, ongoing, large dollar investments. But I think looking for ways that we can support local workforce development is key.
Well, thank you everyone for the opportunity that we have had to present the panelists to you. Hopefully it's been educational for you and you see opportunities for collaborating with the various organizations and helping us move healthcare forward in the state. So thank you to the panelists.